Good day, I am Pat Anridante from BSN 111F, a student nurse from Davao Doctors College. So for today, I'll be assessing the thorax and lungs. So assessing the thorax and lungs is frequently critical for the client's oxygenation status since change in respiratory system can occur either quickly or slowly. So now, the first thing that we need to do is to review the client's medical records if available, for us to know the previous medical history of the patient to provide focus for the physical assessment of the patient. Okay, and also to determine the scope of assessment needed and prepare necessary equipment to save us time and effort. So the equipments we need are examination gown to drape the patient, working gloves to prevent cross-contamination since we might be touching some parts of the patient's face, also stethoscope, skin marker, any light source, alcohol for disinfection, and of course, a metric ruler. So now, after we ensure that the necessary equipments are present, let us now perform hand washing, which I did earlier, to disinfect and avoid cross-contamination with the patients. But now, I'll just do a hand hygiene to deter the spread of the microorganism. Okay, also to wear gloves if necessary. Okay, so now that we're done, let us go and meet the client. So here we first proceed to greeting the client politely and the client's companion if around. Then, introduce myself and verify the client's identity, then ask how the client would like to be called during the assessment, and also establish rapport with the client. Verifying the client's identity helps us to know if we have the correct client, and also greeting and establishing rapport with the client makes them feel comfortable and less anxious. So ensure that the client's comfort, privacy, and confidentiality. Assessment settings should be safe and secured and free from distractions. Okay, good morning, sir. Before anything else, I'd like to introduce myself. I am Pat Anridante, your student nurse for today. So may I know your name, sir?
Josh Ivan Filan.
Okay, sir. So how would you like me to call you?
Ivan.
Okay, Sir Ivan. Before we proceed, I need to know some of your personal information. So may I have your wristband, sir? Okay, sir. So please state your complete name,
Josh Ivan Filan.
your birth date,
March 25, 2004.
and your age.
19.
Okay, sir. Thank you. So after that, I will explain the procedure to the client and how he can participate during the assessment. I will then provide the clients the opportunity to clarify, ask, or raise any concern. This is done to elicit cooperation from the client, and providing the opportunity to ask help us to know if there is more information that our client would like to know more about. So for today, sir, I will be assessing your thorax and lungs. And in the process, I'll need you to take off your shirt and undergarment, and also I'll be touching or palpating your upper extremities. Is that okay with you, sir? Okay, sir. So may I know what language do you prefer to use? Okay, sir, I'm just going to close the door and draw the curtain, sir, for your privacy. Would that be alright to you? Okay. Okay, sir, is the room temperature good for you? Okay, sir, are you comfortable with your position? Don't worry, sir, because all the results and information that will be gathered is secure and will remain confidential, meaning only two of us, as well as your attending physician who are taking care of you, will know. Okay, sir? So do you have any questions? Do you have any concerns before we proceed, sir? Okay, thank you. So now let's proceed in the working phase. Okay, sir, so before going with the assessment, I just want to ask you regarding your health history. Is it okay to you, sir? Okay, so for your current symptoms, sir, do you have any difficulties with your breathing?
No.
Okay, so how about chest pain, sir?
No.
Okay. So how about coughing, sir?
No.
Okay. So any gastrointestinal symptoms such as nausea, diarrhea, or any pain in the abdominal area, sir?
No.
Okay. So let's proceed with your past history, sir. So did you have any respiratory problems?
No.
Okay. So did you undergo any trauma or thoracic surgery?
No.
Okay. How about prior medication intake, sir?
No.
Okay. So do you have any allergies?
No.
Did you have any previous diagnostic or lab results?
No.
Okay. So in your family, sir, did anyone has lung disease? Okay. How about smokers? Okay, sir. Do you smoke? Do you exercise?
Yes.
Okay, that's good. And do you sleep enough, sir?
Yes.
Okay. Alright, sir. Thank you so much. So now we'll now proceed with assessment. In here, I have here your shirt, sir. Please remove your shirt, sir, and kindly wear this examination gown. I will only expose areas that will be assessed and the rest will remain covered, sir. I will also touch parts of your anterior and posterior thorax, sir. And I will ask you to breathe as part of the auscultation, sir. Is that okay with you? Okay, any further questions, sir, regarding with the assessment? Okay, so now we check for any signs of respiratory distress such as nasal flaring, pursed lip breathing, and retractions, or problem with oxygenation. Remember to observe the color of face, lips, chest, and fingernails because intercostal retractions, nasal flaring, and pursed lip breathing indicate airflow obstructions and poor ventilation. And while I was asking the client earlier, I already inspected it and I see no signs of respiratory distress. Also, palpate suprasternal notch and note the position of the trachea. So sir, is it okay to touch your neck? Okay, I'm just going to palpate it, sir. Okay, let us now proceed on examining the posterior thorax and lungs. So first, we inspect for configuration. Chest configuration refers to the overall structure of the chest, shape and anterior-posterior diameter versus transverse diameter. So have the client stand with both arms at the sides, then I'll stand behind the client and observe the position of the scapulae, the shape and the configuration of the cell wall. Any abnormal findings such as funnel, pigeon, barrel chest, or any must be noted. Okay, sir, so can you please stand up? And both of your hands are at the side. Okay, thank you. So, then we inspect for spinal alignment to determine any abnormal curvature of the spine. So, in a lateral position, observe the three normal curvatures: the cervical, thoracic, and lumbar of the spine. So, to assess for its deviation, observe the following client from the rear and have him bend forward at the waist and observe from behind. Alright, sir, I need to inspect your spinal alignment to see if there are any deformities. I'll be asking you to bend forward at the waist level. Is that alright? Okay, sir, so please bend. Okay, sir, thank you. So you can stand straight now and sit. Thank you so much. So now let's now proceed on palpating the posterior thorax by assessing the temperature, the integrity of all chest skin, and palpate all thorax areas for bulges, tenderness, or abnormal movements, especially for clients who have respiratory complaints. Alright, sir, I have to touch your chest, sir. Will that be okay? Okay, so remember to avoid deep palpation for painful areas, especially if a fractured rib is suspected. In such a case, deep palpation could lead to displacement of the bone, fragment against the lungs. So upon palpating, sir, your skin is intact, there is uniform temperature, your chest wall is intact, and I did not observe any tenderness or masses, which is a normal indicator. Okay, so we will now palpate for respiratory excursion. So which is the movement of the thoracic diaphragm during breathing. Here, we place the palms of both of our hands over the lower thorax, T9 to T10, with your thumbs adjacent to the spine and your fingers stretched laterally, like a butterfly figure, like this. Alright, sir, so I have to touch your back. Is it okay with you? Okay, sir, can you take a deep breath? Okay, exhale. Okay. Okay, thank you. So, while the client is doing that, observe the movement of your hands and any lag in movement. So, upon observing, sir, there is a full and symmetric thorax expansion, which is normal. Okay? After that, we palpate for the vocal primitus to assess for increase or decrease of the lung density. We place the palmar surface of our fingertips or the ulnar aspects of our hand or closed fist on the posterior thorax, starting near the apex of the lungs. So repeat the 2 steps, moving your hands sequentially to the base of the lungs. Start toward the middle at the level of the left scapula over the apex of the left lung, and move your hand left to right, comparing findings bilaterally. So move symmetrically downward and out to cover the lateral portion of the lungs at the bases. Compare the primitus on both lungs and between the apex and the base of each lung, using either one hand and moving it from one side to the client to the corresponding area on the other side, or using the 2 hands that are placed simultaneously on the corresponding areas each side of the thorax. So sir, I'll be touching your neck, sir. Is that alright? Okay, sir. So can you say 1, 2, 3?
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
Okay, thank you. Okay, sir. So upon palpating, sir, vocal primitus is bilaterally symmetrical, and it is most seared on the apex of the lung, which is normal indicator. Okay. So next is, after the palpation, we move on to the percussing the thorax to assess for lung resonance. So first, we ask the client to bend the head and fold the arm forward across the chest. This separates the scapula and exposes more lung tissue to percussion. So we then percuss in the intercostal spaces at about 5 cm or 2 inches intervals in a systematic sequence, and compare one side of the lungs with the other. So percuss the lateral thorax every few inches, and starting at the axilla and working down to the 8th rib. Okay, sir, so can you bend your head and a little bit and form your arms like this? Okay, sir, so I'm going to percuss now, okay? Okay, I'll touch your body, sir. Okay, thank you so much, sir. Again, by the use of percussion to measure diaphragmatic excursion, which identifies the level of the diaphragm during breathing, we percuss downwards from the above the expected level of the diaphragmatic dullness until dullness is definitely heard, and mark the level of full expiration, and have the patient inhale deeply and hold it in, then percuss downward to the level of dullness and other side. So then measure the distance between expiratory and inspiratory levels of dullness. Okay, sir, so now I'll be percussing your back, sir. Is it okay with you? Okay, sir, so please inhale and hold. Okay, exhale. Okay, sir, I'll be marking it, sir. Is it okay? Okay. And now, sir, inhale and hold. Okay, exhale. I'll mark it, sir, okay? Okay, sir, inhale. And then exhale. Hold. Okay, inhale, sir. I'll be marking it. Okay, then exhale. Hold. Okay, I'll be marking it, sir. Inhale. Okay. That's all. Thank you so much, sir. So now for the auscultation. Hereafter, we auscultate for breath sound to assess airflow through the airways. We only do it by placing the diaphragm of the stethoscope firmly and directly on the posterior chest wall at the apex of the lung at C7. For, for each area of auscultation using the systematic zigzag procedure used in percussion. Remember to listen at each point to the breath sound during the ventilation. So then compare the findings at each point with the corresponding point on the opposite side of the thorax. Note the location on the chest wall where adventitious sounds are heard as well as the location of each sound within the respiratory cycle. Okay, sir, so now I'm going to auscultate using stethoscope. Is it okay with you? Okay. So, okay, sir, so can you breathe deeply through your mouth? Okay, so inhale, exhale, 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 inhale, exhale. Okay, thank you so much, sir. Okay, sir, so upon auscultating the posterior thorax, sir, there are no signs of abnormal breath sounds such as crackles and wheezing. This means that there are vesicular and bronchovesicular breath sounds, which is a normal indicator. Okay, so again, we auscultate, but this time for voice sound, we will do the same procedure earlier. So place the diaphragm of the stethoscope firmly and directly on the posterior chest wall at the apex of the lung at C7. To auscultate now, sir. So for bronchophony sound, sir, can you please say 99? Okay, wait. Okay, say it.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay. So now, sir, for thoragophony, please say E.
E, 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 E.
Okay. Next is whispered pectoral eulogy. Okay, sir, can you whisper 1, 2, 3? Okay, sir, thank you so much. So by doing that, do not forget to listen at each point to the breath sound during ventilation. Then compare the findings at each point with corresponding point on the opposite side of the thorax. Again, note its location on the chest wall where adventitious sounds are heard as well as the location of each sounds within the respiratory cycle. Okay, sir, so upon auscultating, I observe that the bronchophony sound is clear, the agophony sound is also clear, and the whispered pectorality is clear. So using the stethoscope, which are all normal indicator. Okay, so now that we're done assessing the posterior thorax and lungs, let us now proceed on assessing the anterior thorax and lungs. So first is we inspect for breathing patterns, because various respiratory patterns have localizing significance in the patient with altered consciousness. Observe the characteristic of chest, rise, and fall and its rate. So, I'm going to observe. Okay. Okay, so then we'll proceed on inspecting the costal angle to evaluate expansion of thoracic cage. Note for any abnormal findings. Okay. After inspecting and noting if there are any abnormalities, let us proceed on palpating the anterior thorax for tenderness, sensation, surface masses, crepitus, and firmitus. So we do it by using our fingers, palpate tenderness and sensation. So palpate with your hand, position over the left clavicle, which is located over the apex of the lung, and move your hand left to right. And then compare the findings bilaterally. Remember to move systematically and accordingly as suggested, then repeat for crepitus and firmitus. Okay, sir, I'm going to touch your clavicle, sir. Okay. So now, afterwards, let us now palpate for respiratory excursion, which is the movement of the thoracic diaphragm during breathing. So place the palms or both hands along the lower rib cage with your thumbs along the costal margin. It seems like a butterfly, the same as the palpation of posterior thorax. Okay, sir, so I'll be touching your lower thorax. Is that alright with you? Okay, so, okay, sir, please take a deep breath. Okay, so now I'm going to observe the movement of my hands. Okay, sir, deep breath, please. Okay. So after that, we then proceed on percussing the anterior thorax to assess for lungs resonance. We begin above the clavicles in the supraclavicular space and proceed downward to the diaphragm. Then compare the lung on the one side of the lung on the other side. A female patient displays the breast to facilitate percussion of the lungs. Okay, sir, now I'm going to percuss. Is it okay to touch your chest, sir? Okay. Okay, thank you. Now we auscultate for breath sounds, specifically the trachea and the anterior thorax. This is to assess airflow through the airway. Then place the diaphragm of the stethoscope firmly and directly on the anterior chest wall. So for each area of auscultation, using the systematic zigzag procedure used in percussion, use the systematic zigzag procedure. Listen carefully at each point to the breath sound during auscultation. Okay, so sir, now I'm going to auscultate. Okay, sir, now I'm going to touch her. Is it okay to touch? Okay, so breathe deeply, sir. Okay. Okay, thank you, sir. So now for the summary and closing phase. So, sir, as I have seen earlier, sir, I've assessed your anterior and posterior thorax and lungs. There are no thorax deviations. And as I auscultated your breathing sounds, I can hear a vesicular sound over peripheral lung and bronchovesicular sounds between your first and loud intercostal space lateral to sternum. Also, sir, your bronchial sounds over trachea. So I also didn't hear any adventitious sound, sir, and there are no presence of respiratory diseases. And your respiratory rate, sir, is 16 CPM. All in all, sir, are normal. Okay, sir. So as much as possible, sir, avoid yourself being exposed to environmental hazard such smoker. So do you understand the plan about resolving health concerns, sir? Okay. So do you have any clarification or concern about the assessment? Okay, so that's all for assessment, sir. Thank you so much for your cooperation, sir, and have a nice day. And now, we're going to perform hand hygiene. and document the findings in the client record using printed or electronic forms or checklists supplemented by narrative notes when appropriate. It is important to document all relevant and pertinent information, because if it is not documented, then it means not done. And it can be also used by healthcare professionals for the continuity of care. So that's all for the assessment of thorax and lungs. Thank you.